Good day. Thank you for joining us. Today we're going to talk about urinary CTX-II, its clinical utility and interpretation. My name is Andrea and I work in the Consulting and Education Department here at Meridian Valley Lab. First, we need to learn what urinary CTX-II is. The biomarker CTX-II originates primarily from calcified cartilage and reflects changes at the interface between the bone and articular cartilage. Early detection of changes in bone and cartilage, as in osteoarthritis, can preserve joint function, decrease pain, and prevent disease progression. CTX-II may be a more accurate marker than some other urinary cartilage biomarkers for rapidly progressive arthritis. Osteoarthritis results in pain and joint damage. It's also known as degenerative joint disease, and it's a progressive disorder in joints that's recognized by a gradual loss of cartilage, and we can clearly see the difference here between the normal joint space and the arthritic joint. It can also present as bone cysts or bony spurs that are attached to the bone. The Center for Disease Control, the CDC, predicts that by 2020, arthritis will actually have more new patients in its diagnosis than any other disease form in America. And this is important because obesity is an important risk factor for osteoarthritis. It's also an important risk factor for metabolic syndrome or type 2 diabetes. And both osteoarthritis and type 2 diabetes or metabolic syndrome share multiple risk factors. Up to 60% of those with osteoarthritis also have metabolic syndrome. In fact, it's so common to see the two together that metabolic arthritis is considered a new subtype of osteoarthritis. So a bunch of different people can get osteoarthritis for different reasons. First reason is trauma. This can happen in younger patients, and it can happen due to repetitive stress, occupational stress or sports-related repetitive injury, or it can just be a single episode of acute joint trauma. Aging is another reason for osteoarthritis. After 65 years old, there's an increased incidence without any trauma or any comorbid conditions. And then lastly, as we've learned, metabolic syndrome or type 2 diabetes is another risk factor for osteoarthritis. And these are usually younger patients. We can start to see arthritis in this population around 45 years old, which means they act older when they're younger. They're also usually obese or have an increased body mass index, and they'll have at least one other symptom of metabolic syndrome, most of which are cardiovascular risk factors as well. They'll also have inflammatory profiles that are positive or higher than normal. And again, we need to remember that up to 60% of the U.S. population may have both arthritis and type 2 diabetes or metabolic syndrome at the same time. So early detection is important. Osteoarthritis currently is most commonly diagnosed due to symptoms and imaging studies. Now, diagnosis can be extremely accurate through physical exam, but especially with joints, it depends on the physician's technique and experience. Radiography is a great way to look at bones, but it requires a fair amount of technical support and specialized interpretation, which is costly. MRI is an even higher cost, has even lower availability, and there's less consistency in the way that those results are interpreted. Now, the other problem with this is that physical exam and radiography evaluations are only effective at diagnosing osteoarthritis once the disease has reached an irreversible stage. And importantly, changes in urinary CTX-II can happen before that irreversible stage. We can find it earlier, usually when pain starts, and usually before the changes are visible on the X-ray. And this is a great thing because it lets us preserve joint function and cartilage, which can prevent disease progression. So CTX-II makes a difference because it helps us preserve the remaining cartilage. High CTX-II reflects cartilage damage. It's an early warning sign of either bone turnover or cartilage damage, often due to arthritis or heavy exercise. One study in runners, swimmers, and rowers clearly showed higher levels of CTX-II in runners because of that mechanical damage to their knees. and rowers because of the bone remodeling and joint stress in their shoulders. Now, we want to preserve cartilage because there's little to no cell division in normal adult cartilage cells or chondrocytes. And there seems to be no ready supply of stem cells to replace chondrocytes if they die. So we want to make sure that we find arthritis and find joint damage while we still have cartilage to work with to preserve joint function. So that urinary CTX-II level correlates with joint pain rather than visible changes on the X-ray. Remember, by the time the X-ray shows damage, that joint destruction is irreversible and you're stuck with the joint that you have. Also, around menopause, CTX-II and other bone health markers can start to increase as estrogen and other hormone levels start to decrease. This can be another early warning sign for us. We may need to check bone density, or we may need to do a hormone assessment on our patient to see how we can help them further. We also know through studies that cartilage degradation, that cartilage destruction, is lower and slower in women receiving hormone replacement therapy. And we want to be able to stop this process while we have cartilage to work with to preserve those joints, and we have strategies that can help us do that. The first and most important one, especially for an obese or an overweight patient, is weight loss, and that does involve both diet and exercise. And this is where choosing that right kind of exercise, the one with the lowest CTX level, is important. Moderate low impact exercise has the least amount of oxidative stress inside the cartilage cells. And that's the one that we would want to choose to preserve the cartilage. We'd also want to provide healthy fats like omega-3s. We'd want to provide resveratrol. Through SIRT1 signaling, it promotes chondrocyte survival. It lets those cartilage cells live. And that's important, and it prevents their damage. We want to provide the right vitamins. Vitamin D is important to prevent inflammation. Vitamin C and K help chondrocytes form cartilage, do collagen cross-linking, and maintain cartilage health for us. And then lastly, if our patients are older, they may be going through menopause or andropause, we want to evaluate their hormone levels using urine hormone testing. And if they're low, we want to consider bioidentical hormone replacement to help preserve that cartilage. So we may choose to do a urinary CTX evaluation on its own because a patient has an achy joint, or we may choose to do it because we've seen a patient who has very low hormone levels and we want to make sure their bones are okay, or we may choose to do it in a patient who's starting to show signs of metabolic syndrome or prediabetes. So in conclusion, the rate of osteoarthritis is increasing in the U.S. population, and we want to get ahead of that curve. Osteoarthritis is associated with metabolic syndrome or type 2 diabetes in about 60% of patients. By the time you can see that joint damage on an X-ray, it's too late. And urinary CTX-II can help us find that joint damage before it's visible on the X-ray while we can still do something about it. Using early detection and CTX-II, we have an opportunity to intervene at an early stage and preserve cartilage and joint function for our patients using diet, nutrition, and lifestyle. I thank you for your kind attention. If you want to learn more about CTX-II or any of our other testing, please visit us at meridianvalleylab.com or call us at 855-405-8378. Thank you and have a great day.